This is a short presentation concerning physical interventions and medical conditions. And what we're going to cover, we're going to be looking at assessing the risk and need, positional asphyxia, excited delirium, head injuries, second impact syndrome, asthma and heart disease, and we're also going to include some information in relation to various service users, for example Down syndrome service users who may also have weak muscle tone, excessive joint flexibility, as well as heart defects and diseases. So dealing with challenging behaviour, which is also known as violence in the workplace, is a highly complex area. Main areas focused upon tend to be the service user or the client and the actual physical intervention techniques used. However, there's other areas that need to be addressed. This includes the management of challenging behaviour, particularly under legislation such as the Health and Safety at Work Act and also concerning corporate manslaughter, the staff member, other people in relation to your duty of care to them, and the environment. The topics covered today are not covered in their entirety, but we'll give you some basic information which you can contact us for further details on. So assessing the need then and assessing the risk, it's essential that all workplaces and service providers conduct assessments of risk for their staff and clients. We need to know what physical or psychological risks are highlighted to our staff and service users so we can properly assess their needs. Assessing the need will then look at service users and staff based upon their unique demographics and underlying medical conditions. Intervention techniques may well be effective and appropriate with most people, but may not be suitable for particular service users or for particular members of staff to actually apply. The unique and individual assessment of risk and need approach will assist greatly in ensuring professional and safer handling of intervention incidents. Ultimately, if a service user dies during a physical intervention incident, then the service provider, as an individual or an organisation, can be liable. All workplaces are required to conduct an assessment of need for all workplace activities that they conduct and associated risks. To assist with this, there's always off-the-peg shelves of standard conditions. However, current courts and cases are looking there at reasonable adaptations in order to make them safe. And if you're already in the care situation, such as education care or custody, it's about adaptations for safe and effective care for both the service user and the members of staff. Firstly, I must emphasise that no physical intervention or restraint is safe. There are always risks for the service user, the staff members and others nearby. The safer handling of challenging and/or vulnerable people is a target, but management and staff need to adopt a risk-based approach for knowledge and skill to reduce likelihood of severity. Considerations. Many individual issues will impact upon the safety of intervention processes, and these will include special educational needs and disabilities, neurological issues such as dementia or Alzheimer's, suicide and self-harm tendencies, acute behaviour disturbances, physical issues such as asthma, infections, head injuries, brain injuries, heart disease, diabetes, sickle cell, excited delirium, positional asphyxia, etc., and psychological issues such as depression, anxiety, claustrophobia, OCD. During the escalation to crisis, a person increases a variety of hormonal releases, for example epinephrine, adrenaline, which can increase to a toxic level within the body. Produced by the adrenal gland, it increases the size and speed of the heart to pump blood and oxygen to the muscles for fight and flight response. For fit people with no underlying medical issues, the body can usually deal with this, but for people with unhealthy or damaged organs, this can prove problematic. Naturally produced epinephrine during a physical intervention situation can result in heart palpitations, respiratory difficulties, and ultimately respiratory failure or cardiac failure. The person's heart will also increase in speed in order to deliver more oxygen to the main muscle groups for the fight and flight response. This creates a demand for oxygen increase in the body, so any intervention which reduces the increased need begins to trigger impacts of low oxygenation in the body and mind, hence begins the start of a downhill spiral where existing conditions are made worse and oxygen reduction to the brain reduces logical thinking. A first aider is not a medical practitioner, and although they can greatly assist for observations and immediate care, I would recommend that professional medical attention is immediately sought if any of the following conditions occur to either the restrained person or the staff member. Those are that any person appears to be suffering from any physical injury or illness, any person is injured as a result of the intervention, any person appears to be suffering from a mental ill health condition, any person appears to have a drug, and that's prescription or illegal drug, or alcohol dependence or withdrawal, or appears to need medical attention for any condition, including trouble breathing, other respiratory concerns, chest pains, bleeding from the nose, ears or mouth, bruising or swelling behind the ears, loss of vision, paralysis to the face or any other body part, loss of consciousness, difficulty walking or moving or vomiting, or the service user or staff member requests a medical examination. The risk assessment process includes assessment that the risk presented to the service user and the member of staff. Every service user is an individual, and each event, each day, may have dynamic changes to the health and well-being of the individuals involved. Even the weather can impact upon the likelihood and the severity. In addition to having written assessments, staff need to understand the importance of dynamic risk and need assessment and the ability to deviate from usual procedure in extraordinary circumstances. Information for this assessment is available from many sources and includes the service user themselves, their friends, family and associates, witnesses and all staff, previous knowledge of all people concerned, circumstantial information based upon events of high risk, and a database information from other professionals. A process for conducting the risk assessment for service users and staff could include gathering all information, identify the hazards, evaluate the risk, identify control measures such as conflict management, resolution and reduction of triggers, implement control measures with suitable and sufficient assessment processes, agree care plans for both the service user and the staff, inform others of details who need to know, monitor and review and repeat the process. So let's have a look at positional asphyxia. Positional asphyxia is a risk when a person is being restrained. Safer airway positions are the target at all times. History shows that laying people down, either in the prone or supine, prone position is on your front, supine position is on your back, reduces the airway management. Any airway management compromise has potential catastrophic risk and should be avoided if possible, and if not possible then the risk removed urgently. Positional asphyxia is not a straightforward suffocation, it is having the body in a position whereby the oxygen intake is lower than the demand. As time passes, this creates a lower oxygen saturation in the restrained person, causing organs to fail. The time limit can be from seconds to hours and beyond. Body weight of the staff member on the service user should be avoided. Factors that increase the risk of positional asphyxia include positions that result in complete or partial obstruction of the airway, pressure applied to the back, neck, torso or abdomen, a person in the prone position laid on their front face down, restriction of the shoulder girdle or accessory muscles of respiration, obesity, a child, a small adult or elderly person, a person with underlying health problems, heightened stress levels, or respiratory muscle failure related to earlier violent muscular activity, such as a violent struggle. Excited delirium. Excited delirium is fortunately uncommon, but is extreme and life-threatening. People who are suspected of suffering this should only be restrained in the most extreme circumstances. Head injuries are known to contribute to this condition, and head injuries may occur during a physical intervention incident. Symptoms of excited delirium include a high mental and physical arousal of the fight or flight response, breathing problems, high body temperature, insensitivity of pain. Excited delirium is often triggered by a response to drug abuse or overdose, but also includes mental illness, particularly connected to abrupt stoppage of medication, physical or noxious chemical control, electrical stimulation such as a taser. Clinical features presenting include tachycardia, hypothermia, hypertension, acidosis. The four main phases of excited delirium are elevated temperature, agitated delirium, respiratory arrest, cardiac arrest and death. For head injuries, you should also see our video in relation to head injuries and brain injuries. But a blow to the head can result in bruising or bleeding inside the skull, as in the brain. Not all head injuries are visible, and you need to be aware of contre-coup injuries, that is where the front of the head's impacted. For example, you can actually have an injury at the rear of the head because of the way that the brain is shaken inside the skull. Complications may occur at any time, and high-risk people include the elderly and the young, as their capillaries are delicate and easily damaged. Complications may occur at any time after the event, and staff should be aware of risks associated with head injuries. For example, rapid deterioration of the service user during or post physical intervention. Observations post-incident are critical, especially if first aid processes are implemented, which may mask signs and symptoms. Second impact syndrome is also a consideration. This is where the brain swells rapidly and potentially catastrophically after a person sustains a second concussion before the symptoms from an earlier one have healed. Most cases of second impact syndrome occur in young children and adults, particularly athletes. The condition is rare, but still a consideration for physical intervention, first aid and medical response preparedness. In 2002, a high school football player from Texas called Bill Benson suffered 2 concussions within 2 weeks. He collapsed and died 6 days later. The cause of death was recorded to be second impact syndrome. In 2007, Texas implemented a program of basic emergency and safety training for sports officials in education settings concerning second impact syndrome. In 2006, a similar event occurred for a 13-year-old student called Zachary. Though he survived, he sustained significant life-changing injuries. In 2011, we've got 14-year-old Benjamin Robinson, who collapsed during a game of school rugby in Northern Ireland. The coroner ruled Benjamin had suffered a concussion during the first few minutes of playing the game, followed by another one about 25 minutes later. Both rugby clashes, the coroner recorded the death as second impact syndrome. A single concussion has the potential for proving fatal during a physical intervention situation where the service user strikes their head against a wall or floor, as a blood clot can occur. Concussions can take days, weeks or months to heal. Therefore, accurate records for service users who sustain any head trauma during physical intervention is essential. Repetitive head injury syndrome is also a similar condition to be aware of. Regarding asthma, service users with asthma are at increased risk during physical intervention for 2 issues: high anxiety causing low oxygenation in the blood, coupled with a restraint which prevents increased oxygenation. De-escalation techniques without restraint should be a high consideration. Then any physical restraint should ensure keeping the airway open, in addition to reducing the anxiety levels of the service user. Ready access to asthma inhalers is essential. When we talk about heart disease, the older we get, the more wear and tear and damage on our hearts. Many elderly care residents have weakened hearts naturally due to age without aggravation of lifestyle factors. If an elderly person requires physical intervention, fatal consequences can easily result, as stress can trigger angina or cardiac arrest. Any person in crisis with or without restraint showing signs of heart malfunction or pain should be immediately sent to hospital via the emergency services. If there is potential for a cardiac arrest or respiratory arrest, the staff involved should be aware of CPR processes and safe airway positions for oxygenation during restraint. Other considerations would be defibrillation machines for cardiac arrest and supplementary oxygen. A group of service users in relation to heart disease, for example, is anyone with Down syndrome. Down syndrome people, they have an increased risk of heart disease and heart defects, also digestive system disorders, hearing and vision impairment, thyroid disorders, and musculoskeletal effects such as weak muscle tone and excessive joint flexibility. Therefore, if you are involved with service users who have challenging behaviour who are also Down syndrome, you need specific adapted training in relation to de-escalation and physical intervention of these service users, as off-the-shelf packages are not suitable or sufficient for anyone who is outside of the mainstream classification. If you have any further questions, please do not hesitate to contact us at Total Train. My name's Joanne Caffrey. Thank you very much.